Welcome back. So today we have a very interesting case, a very important one. So let us start. A young boy has a sore throat and is having trouble in breathing and swallowing. A large white gray membrane is noticed on the oropharynx. STT wave changes on electrocardiogram and slight paralysis of tongue are noted. On further examination, low blood pressure, edema in legs, and cranial nerve palsies are found. The doctor starts immediate treatment and sent a throat swab culture to confirm the diagnosis. So, what is the most likely diagnosis here? What could be the most likely causative agent? What is the pathogenesis? Which are the clinical features, complications? Which investigations you would like to do for diagnosis confirmation? And what is the treatment and preventive strategies? So, let us start with that. So, as all of you have guessed it right, it is respiratory diphtheria, and the causative agent is Corynebacterium diphtheria. It is also known as Klebs-Loeffler bacillus, and we'll come how we have uh, come to that part, how we have diagnosed this thing. But before starting further, let us understand what is the classification of this bacteria, that is Corynebacteria. And though Corynebacterium diphtheria is the most pathogenic among all the Corynebacteria, it is worthwhile to note other Corynebacteria which are important medically. So, if we see the classification of Corynebacteria, you can divide that into two groups. One is non-lipophilic and another is lipophilic. The non-lipophilic group is the group which usually causes respiratory diphtheria or upper respiratory tract infection, in which the Corynebacterium diphtheria is most common, as well as it is the most pathogenic Corynebacteria overall for the humans, and it causes both cutaneous as well as respiratory diphtheria. And based on its virulence and toxin production capacity, there are four biotypes there from increasing to decreasing virulence, that is gravis, intermedius, mitis, and Bellfield. And Corynebacterium ulcerans, it is usually a zoonotic strain. It usually infects cows, but humans can acquire infection via cow's milk. Similarly, Corynebacterium pseudotuberculosis, which is also known as Prisonocard bacillus, uh, that causes pseudotuberculosis in sheep and suppurative lymphadenitis in dogs, but rarely it can also cause human infection. So these three species, they are non-lipophilic. Rest of the corynebacteria which are significant, they are usually lipophilic. For example, one which is emerging nowadays, that is Corynebacterium jacem, which is usually a skin flora, usually in hospitalized patient, and it can cause bacteremia, endocarditis, and meningitis, especially in immunocompromised patients. And interesting thing is that this is a multi-drug resistant corynebacteria, and it only respond to vancomycin. The second one such is Corynebacterium urealyticum, which is also a skin flora, and it usually causes pyelonephritis and white stone formation, which leads to alkaline encrusted cystitis in immunocompromised patients, especially the renal transplant recipient. And Corynebacterium xerosis is the only non-diphtherial corynebacteria which shows metachromatic granules. Now, what is metachromatic granule? We will learn in detail later on in this session, but these are the polar granules which are situated at both poles of the bacteria, and it is usually seen in Corynebacterium diphtheria. But apart from Corynebacterium diphtheria, Corynebacterium xerosis is the only one which shows this granule. So, this is an important point to remember. Then Corynebacteria immunotissimum, that causes erythrasma, which is a localized skin infection of axilla and groin. And characteristic thing is that when you do a Woods lamp examination, the lesions will fluoresce coral red color. And another one is Corynebacterium pseudodiphtheriticum. It is a throat commensal, but it can cause exudative pharyngitis, which mimic diphtheria, and endocarditis, especially in immunocompromised patients. So, if person is immunocompromised and showing diphtheria, respiratory diphtheria, then this pseudodiphtheriticum should be kept in mind. Then Corynebacterium hoffmanni, this is another lipophilic corynebacteria. So, this is the classification. There is another term which some textbook and some people use, that is diphtheroids. Now, what is this diphtheroids? It is a term to denote the all other corynebacteria apart from Corynebacterium diphtheria, so non-diphtherial corniforms, and which are normal commensals, usually in throat, conjunctiva, and skin. And they usually causes opportunistic invasive infection in immunocompromised patients. And they are differentiated from Corynebacterium diphtheria by their uniform staining, their parallel arrangement, which is also known as palisade arrangement in rows, and there is no metachromatic granule. The only exception is, I already earlier discussed, that is Corynebacterium xerosis. So this is the classification in terms of Corynebacteria. Now coming back to our case, uh, as you can see, the person has sore throat with dyspnea and dysphagia. Membrane is there on the throat and oropharynx, and there is cardiac changes in form of rhythm. There is paralysis. So neural involvement is there. Person is in hypertension, and edema is there. So heart involvement again, and cranial nerve palsies are found. So again, neurological involvement. An immediate treatment requiring condition is there, and for which you take a throat swab culture. So it is a pharyngitis with cardiac and neurological complication with membrane in the oropharynx. So this is a typical presentation of respiratory diphtheria. So what is the pathogenesis? Pathogenesis is that Corynebacterium diphtheria has two strains. One is toxigenic and another is non-toxigenic. That means one which does not produce toxin. They usually cause cutaneous diphtheria, in which there is an ulcer. It starts as papule and vesicles and then burst into ulcer. But these ulcers, they are coated with pseudomembrane. And this is also known to cause the peritonitis in peritoneal dialysis patients and opportunistic infections in immunocompromised patients. If it is toxigenic corynebacteria, then they can cause diphtheria. And which are the three toxin producing strain? If you see, these are the three non-lipophilic bacteria, that is Corynebacterium diphtheria, ulcerans, and pseudotuberculosis. And obviously, out of which diphtheria is much more common. And Corynebacterium diphtheria is an exclusive human infection. So humans are the only reservoir and source. And usually carriers are more uh, source of infection than cases. So 95% time it is the throat or nose of carriers which is the source of infection. And in tropics, skin lesions are also common. And nasal carriers, they shed more frequently than throat carriers. So that's why they are more dangerous compared to the throat carriers. If we talk about Corynebacterium ulcerans, and this is very important because this is basically a zoonotic infection. It usually causes infection in animals. So you can acquire this infection from contact with animals. Spread. If you see that Corynebacterium diphtheria has person-to-person or close contact with infected secretion, and ulcerans is, I earlier also mentioned that it is a milk-borne infection, and yes, there is a possible person-to-person infection. And cases and contexts of cutaneous diphtheria, both in case of Corynebacterium diphtheria and ulcerans, may develop respiratory diphtheria. Now, what is the mode of transmission? It is most commonly it is droplet inhalation, but yes, it can also be transmitted with direct contact with skin lesions in both the cases. Now, what are the risk factors? So usually we have seen that earlier it was involving preschool children, which is usually aging between 1 to 5 years. But nowadays we are seeing that incidence has increased in school age children, that is 5 to 10 years of age, because of widespread vaccination. This 1 to 5 year age group is immune, and now infection is shifting to 5 to 10 years, and adults due to waning immunity over the years. And India has highest burden of diphtheria, that is 70% of cases in the world. Now, how this toxigenic bacteria they acquire this toxin and what is the mechanism? Let us understand that. So, diphtheria toxin gene is carried by a virus, a bacteriophage, also known as beta corynphage, and it causes lysogenic conversion. And only this lysogenic corynebacterium diphtheria they become toxigenic. They acquire this property of toxin production, and they can able to cause respiratory diphtheria and systemic complication and diseases. So what happens is toxigenic bacteria, it infects nasopharynx through respiratory droplets. It creates necrosis and gray fibrinous exudate, which is known as pseudomembrane. So pseudomembrane is usually necrosed tissue which has dried up bacteria, WBC. And this pseudomembrane, if it covers the airway, it blocks the airway, it causes airway obstruction and asphyxia. And bacteria multiply there and it releases diphtheria toxin. Now, diphtheria toxin, it is an AB toxin. That means it has A component and B component. The B or binding portion, it is responsible for binding this toxin to the host cell receptor. And the A portion or active portion is then internalized. And this active portion or A portion then causes the main mechanism. That is, it causes the ADP ribosylation of elongation factor 2, and this elongation factor 2 is involved in translation, that is protein synthesis. So due to this ADP ribosylation, it prevents the protein synthesis or translation step in host cell, and that leads to inhibition of protein synthesis. And then this toxin has affinity towards heart, nerve, and adrenal glands. So it enters into the systemic circulation and causes cardiac and neurological complication. Cardiac complication in terms of arrhythmia and myocarditis, and neurological, though they happen late in the disease, usually in form of cranial and peripheral nerve palsy. Now, toxin production requires optimum ion concentration. If iron is too much or too less, toxin cannot be produced by bacteria. That is one important thing to remember. And another bacteria which releases a toxin which has similar mechanism of action is Pseudomonas aeruginosa, which releases exotoxin A, which also causes inhibition of protein synthesis by similar mechanism to diphtheria toxin. So this is frequently tested in some of the MCQs that I have encountered with. Clinical presentation. So incubation period is usually 2 to 5 days, maximum 10 days. And there are two presentations. One is respiratory diphtheria and another is cutaneous diphtheria. So respiratory diphtheria, if it is a mild disease, it can remain as nasal diphtheria. So mild or chronic nasal discharge will be there, and it could be clear or it can be bloody depending on the severity. And the classical respiratory or fascial diphtheria, also known as pharyngeal diphtheria, that is the classical case in which the inflammatory necrotic ulcers are produced and they are covered by a leathery grayish white pseudomembrane. And I already told you that pseudomembrane is nothing, it is necrotic cells, fibrin, RBC, neutrophils, and bacteria. And it is adherent to the underlying structure, that is tonsil, oropharynx, and pharynx. So that is the thing which will separate it from true membrane clinically, because true membrane will get easily separated and it is non-adherent. But you should not try to taste this out uh, because it may lead to bleeding and asphyxia. So a bull neck is basically huge edematous swelling of neck and tonsil, and this is a very severe presentation of diphtheria. And usually, patient has foul breath, thick speech, noisy breathing, which is known as stridor, and sore throat, fever. And if not treated, it can cause complications and death. So that is the classical diphtheritic presentation, which is also seen in our case today. And laryngeal diphtheria, because larynx is involved, so there is hoarseness of voice, there is stridor, that is noisy breathing, and this is due to pseudomembrane extension to larynx and bronchial airways, which can also cause asphyxia and fatal airway obstruction. So this is a very emergency condition to treat. Then cutaneous diphtheria, that is the second presentation, and it is usually on exposed part of body, usually limbs. And as I already told you, that lesions start as vesicle and they form a clearly demarcated area of lesion. And sometimes single, sometimes multiple lesions are seen. And ulcers may be very difficult to distinguish from impetigo. And lesions are usually covered with ashar, a hard, slightly raised bluish gray membrane is also seen. So that is cutaneous diphtheria. Now, this diphtheria toxin, if it enters into systemic circulation, then you need to see more complications, and these are more likely after respiratory diphtheria. So, one complication is very common, that is airway obstruction, and that is mainly due to the pseudomembrane extension into airway. But toxin mediated to complications, they are like cardiac complication, myocarditis, that is basically arrhythmia and dilated cardiomyopathy, which are seen. Neurological polyneuropathies are seen and may mimic Guillain-Barré syndrome, and palatal palsies, ocular muscle palsy, limb weaknesses, diaphragmatic palsy. So various neurological manifestation and paralysis is seen. So this is a complication of diphtheria. Now, which investigations we would like to do? So if it is a cutaneous diphtheria, we would like to do a wound or ulcer swab microscopy and culture, and wound swab may contain additional causative organism that is possible. While respiratory diphtheria diagnosis is usually clinical, and you should not wait for culture report to start treatment. I am emphasizing this again. You should not wait for culture report to start treatment. You should start treatment immediately based on your clinical diagnosis. That's why to diagnose diphtheria clinically is at most important. But laboratory diagnosis is required. Why? Because you want to confirm your diagnosis. Second, you want to initiate public health control measures, then you require lab report. And for epidemiological purposes, you need to do this laboratory diagnosis. So yes, you have to send throat swab for microscopy and culture, but please remember, some people they try to scrap the pseudomembrane. Please do not touch the pseudomembrane. Avoid scraping the pseudomembrane as it may result in bleeding and spread of toxin. Yes, you can gently take a swab from the surrounding areas and even from the pseudomembrane without scraping it. And on microscopy, you will see that club-shaped gram-positive bacilli or rod-shaped bacteria is there, and which have granules at both their poles or ends. That is known as polar granules. And these granules they contain phosphate, polymetaphosphate. And other name for this granule is volutin granules, Babes granules, and metachromatic granules. Why metachromatic? Because whenever you stain this bacteria with Loeffler's methylene blue, this granule they show a blue purple metachromatic color. And you can even use some special stains for these granules like Albert, Neeses, and Pondus. And if you stain it with Albert stain, it will show a black color granule, and rest of the bacteria or bacilli is green in color. And gram staining will show that these granules they are more strongly stained with gram staining, so they are more gram positive compared to the rest of the bacteria. Granules are also present in Corynebacterium xerosis, that also I have proved, and another bacteria known as Gardnerella vaginalis, which is involved in bacterial vaginosis. So these two bacteria also show this metachromatic granules. These are very important questions. Metachromatic granule and very characteristic feature of diphtheria. So very frequently tested on various examinations. So I want you to focus on this question very carefully. Then bacteria arranged at angles, acute angles. So it appears that Chinese letters are written. It is also known as cuneiform arrangement. And why this happens? Because of snapping divisions. As they are dividing, suddenly they got separated, but they remain close together, which result into this particular arrangement. Fastidious bacteria they grow well on enriched media. So you should use blood, serum, or egg, but here blood and serum are used. So yes, they will grow on blood agar. So you will see at 37 degrees centigrade, they will grow. If you are using throat swab, you should provide anaerobic environment. They will grow better. If you are using skin swab, then capnophilic 5 to 10% CO2 environment should be used. And 16 to 24 hours, you will see non-hemolytic or beta hemolytic colonies, depending on it is which corynebacterium and which subspecies is there. If we talk about Corynebacterium diphtheria gravis, they are usually non-hemolytic. Rest of all other mites, intermediates, and Belfin biotypes, they are hemolytic, beta hemolytic. Striatum and Jaicum again are non-hemolytic. So if you see the things which can cause severe complications, they are usually non-hemolytic. That's how I remember them. And if you use selective media, which you should use, then you get a good growth. So Loeffler serum slope, they grow within 6 hours. So if you want a rapid cultural detection, this is the best medium that you can use. And this is the medium which will provide you best metachromatic granule production. And but the problem is that if growth is beyond 6 hours, then other bacteria will also grow. So you are not sure whether it is Corynebacterium diphtheria it is growing or not. So it loses its selectiveness. Plus, if there is no growth after 6 hours, then you are not sure whether it is actually no growth or not. That's why you should rely a final report on another medium which is selective, that is PTBA, that is potassium tellurite blood agar. And here it contains tellurite, so bacteria will grow and they reduce this tellurite into metallic tellurium. And now this tellurium is black in color, so you will see black color colony. And growth may take 48 hours to appear. And if you see that there is no growth after 48 hours, yes, you can declare that there is no growth. But this is more confirmatory medium than any other medium. So it helps in species identification also. So based on this black colony characteristic, you can say whether it is gravis, mitis, intermedius, belfanti, or it is any other species like ulcerans and pseudotuberculosis. Because in ulcerans and pseudotuberculosis, usually dry colonies are seen. But if you see glossy colonies, then mitis, intermedius, and belfanti are seen. If it is matte colony and it breaks easily, then it is gravis in nature. So how to identify the species? Now we have automated instruments, so it has become very easy to identify that is Malditov. You have Vitek, API system is there. But traditionally, we were using biochemical test. So it is worthwhile to remember that which biochemical test will help to decide at least basic identification of important species. So three tests which anyone should do is basically this serum sugar fermentation, pyrazine amidase test, and urease test. And catalase is obviously required because catalase positive is diphtheria. So all colonibacteria, they are usually catalase positive. And that will differentiate it from another bacteria which show this metachromatic granule, that is Gardnerella vaginalis, because it is catalase negative. So that is one point you have ruled out one very close thing which can look similar. Then do pyrazinamide test, and Corynebacterium diphtheria is negative. Now, if you see Jicum, striatum, which may grow on PTBA, they are both positive pyrazinamidase. So you have also ruled them out. Urease test is negative in Corynebacterium diphtheria. So you have also ruled out other two uh, bacteria which are toxigenic and cause similar presentation, that is ulcerans and pseudotuberculosis. So you do catalase test, which is positive. You do pyrazinamidase test, which is negative, and urease test negative. So that ultimately gives you Corynebacterium diphtheria. If you want to further do the switch test, then you should do nitrate reduction test. Nitrate reduction is positive in all the biotypes except belfanti. This is nitrate reduction negative test. So I think this is very useful uh, flowchart, or you can say stepwise manner in biochemical tests to remember. So at local level laboratory or low level laboratory, there is some potential that we can miss or delay the diagnosis because it is not a routine culture report. So, and not all labs are doing this Corynebacterium pharyngeal swab culture. So, care should be taken when interpreting even the presence of diphtheroids because some people they misidentify them as Corynebacterium diphtheria. So that's why it is important whether you are doing this test or not doing this test. If you have an isolate which you think is Corynebacterium diphtheria, then you should send those isolate, not the sample, but the isolate to your reference laboratory, whatever it is. Well, but ideally it should be national reference laboratory for toxigenicity testing. That means because we are not concerned only with Corynebacterium diphtheria, we are concerned with whether it is toxigenic or not. So only toxigenic Corynebacterium diphtheria can cause respiratory diphtheria. So if it is not toxigenic, then it is usually not the cause for the presentation which you are seeing. So yes, you can send it, the isolate, you should, the culture that you have grown to the reference laboratory. And there they will do again its identification either using Malditov or Vitek. And their choice of test is usually PCR, real-time PCR, which will identify as well as detect the toxigenic strain. But a PCR can only detect the toxin producing gene. That's it. whether that gene is expressed or not, that you have to check. So that is checked by immunoprecipitation test known as ELK test. And ELK test is a classical test. We will learn about it. It is very frequently tested in some of the examination. But nowadays we have a better version also, that is ELISA, immunochromatography. Even cytotoxicity on cell lines can also be used to detect toxin expression. But real-time PCR and ALKS immunoprecipitation is the classical way the people are doing it. So ALK immunoprecipitation is basically a immunodiffusion in gel. So what we do, we take a horse serum agar in which we put a diphtheria antitoxin soak filter paper in the center. And now we will streak our culture perpendicular to this paper. Now, what will happen if your strain is toxigenic? If your bacteria that you have streaked, they are producing toxin, the toxin will be released into the medium. Same way, from the filter paper, the antitoxin will also release into the medium. And whenever there is optimum antigen antibody concentration is there, optimum toxin antitoxin concentration is there, you will see a arrow-shaped precipitin band in the gel. And that will confirm that okay, toxin is produced. If you cannot see those band, that means strain is non-toxigenic, though you have find the gene, but toxin is not there, and that is seen in very few cases. Most of the time, if you are seeing the gene, you will definitely get its expression. So PCR is almost identical to this immunoprecipitation test, but some of the cases we have seen where gene is positive but toxin is negative, but it has no such public health significance, so no need to take action there. We should consider it as non-toxigenic. That is what I understood. Now, this test can also test strain relatedness during an outbreak. So during outbreak, you are seeing multiple cases, and for example, you have 4 or 5 such strain. So you can put this strain together, and you can see the pattern. And this we know from precipitation test. If you see a crossover pattern, that means if X mark is formed, then they are unrelated strain. If you see a Y formation, it is partially related strain. And if you see fused V formation in identical strains, so that is the identical strain which is causing the outbreak. So this is about the investigations that you should do. Laboratory diagnosis or laboratory investigation of Corynebacterium diphtheria is a very frequently tested question, and you should be ready with it. But most importantly, what I want to emphasize is that treatment should be started on clinical suspicion without waiting for lab confirmation. And what is the treatment? Treatment based on what is causing the disease. So it is the toxin which is causing the disease. So obviously you have to give antitoxin. So diphtheria antitoxin or DAT is the treatment of choice. And but problem is that this DAT is basically horse derived. It is equine, and you can give it IM or IV. And because it is equine in nature, in some people it may cause anaphylaxis or hypersensitivity. That's why I always give a taste dose before giving the full dose. And if there is no reaction, then you can give the full dose. There are trials undergoing for human DAT. So human diphtheria antitoxin preparation is under development, and whenever that will be available, this will not be needed. Now, what is the dose? That depends on the severity. If you are not seeing pseudomembrane, you can give 20,000 to 40,000 units. If you are seeing the pseudomembrane on pharynx, then give 40,000 to 60,000 units. If it is a very late presentation and you see that bull neck is there, very malignant or severe presentation is there, then you should give 80,000 to 1,20,000 units. So it's depend on your clinical judgment and diagnosis. Okay, so we have neutralized the existing toxin, but what we should do to prevent further release of toxin, we have to kill the bacteria which is causing or releasing this toxin. So for that, we use antibiotics. So penicillin or erythromycin will prevent further release of toxin. So it will remove the colonization or infection. And so antibiotic has no effect on already released toxin, but yes, it can prevent further release of toxin. And disease usually is not contagious after 48 hours of treatment. And we can use 2 consecutive cultures if they come negative after treatment completion. So once your treatment course is finished, then you should check for throat swab culture. And if they come negative for toxigenic diphtheria, you can consider that person is cured. Can be taken as a taste of cure. I don't know whether we follow this in every laboratory in India or but this is what I have gone through some literatures and found out that okay, this is the standard way of doing it. Now, prevention. So Before exposure, how you can prevent it? So droplet precautions, because the disease is transmitted by droplet, and we can give carriers effective treatment so they don't become the source, because carriers are the most common sources of infection, and erythromycin is the best way to treat the carriers. But the best way is to give vaccine. So there are two formulations which I would like to mention here. One is DTAP, which is diphtheria toxoid, formalin treated. It is children doses 25 Loeffler units. So this capital D stands for children dose 25 Loeffler units. Tetanus toxoid, which is capital T, and acellular pertussis component, that is AP, that is giving immunity against Bordetella pertussis, and adjuvant to increasing immunogenicity, and a preservative, that is thiomersal. Same way, another formulation is T small d, that is tetanus toxoid, but adult dose of diphtheria toxin, because adults require lesser doses of this toxoid, that is 2 LF, 2 Loeffler units. So this is very important. If you see a capital D, that means high dose, 25 Loeffler units. If you see small d, it is smaller dose, that is 2 Loeffler units, and it is usually for adults. Now, because my book basically caters Indian students more. That's why I have included schedules in India. Uh, what is the schedule of DPT vaccination in your country? You can post it in comment, and I would happily like to include it in this book. So in India, the primary vaccination, I think most of the places it will be more or less similar. But in India, what we use is DTAP. We use three primary doses. One is given at 6 week, another is 10 week and 14 week. And then we give two booster doses. One is between 16 to 24 months and another is at 5 years. Then we give two booster doses, but here the vaccine we will use is T small d, that is TD vaccine. One is at 10 year and another is at 16 years. So total, if you see, we give seven doses of vaccine for diphtheria prevention, because it is very common in India. That's why we want to ensure that the person is immunized properly against this infection. Okay, if a person is presenting to you as adult and who has not taken any vaccination or partially taken any vaccination, for example, a person is come to you that he has taken primary vaccination before a long time, and you see that okay, uh, now he requires reinforcing doses, then you can give booster doses after its last dose, that is 16 years. Once you've given it, you can give booster every 10 years till 65 years of age. But if a person has come with incomplete vaccination, that is not completed primary vaccination, then you should give three doses, one at zero, that means the day when that person present, then at 1 month, and finally at 1 year. So that is about adult vaccination of diphtheria. Now, protective titer of antitoxin, because diphtheria is basically a toxoid, so it will generate the antibody against this toxin, which is basically antitoxin. So the protective titer is 0.01 units per ml. So more than this will prevent all forms of respiratory diphtheria. Please mind respiratory diphtheria. Vaccination will not be helpful to prevent cutaneous diphtheria, because cutaneous diphtheria is not caused by the toxin itself. It is the bacteria itself which is causing it. And the vaccination cannot eliminate carrier state, and that's why we are treating carriers with erythromycin, right? Now, some people may develop fever and local induration and swelling at injection site, which is very common after vaccination and nothing to worry. Uh, Earlier, we were using whole killed bacterial cell or Bordetella pertussis, because it is a combined vaccine, DPT. So this Bordetella pertussis, whole killed cell, was associated with neurological complication, mainly for children more than 7 years of age. But now we are using acellular component of pertussis, and it has no such complication. So now absolute contraindication to DPT vaccination is only confirmed anaphylaxis to previous dose, or any antibiotic component that is added to the vaccine, for example, neomycin, streptomycin, or polymyxin. Otherwise, there is no absolute contraindication. If you are having a neurological disorder and it is not stable and it is progressive, then yes, it could be a contraindication to DPT vaccination. What if the person is already exposed? So, what is the post-exposure prophylaxis? So, close household contacts. They require a single dose penicillin G, or you can give erythromycin for 7 to 10 days. along with also give a booster dose of PTAP, right? So they do not get the diphtheria, respiratory diphtheria at least. One another thing I have noticed in India in various examination that they ask this question about skik test. Now, this will be in very old papers, but skik test is basically an intradermal skin test. It was an in vivo test, and it is a toxin antitoxin neutralization test. And the end result was is to identify which person is susceptible to diphtheria infection. And this was done in pre-vaccination era. It is obsolete now, but just what it was used for, that will be some historical significance. So that's why I have mentioned it here. So that's it all about diphtheria. I think clinically I have tried to cover most of it. If you find that, okay, in your country or in your region, the practice is a little bit different, do mention it in comments, and I would like to answer your queries. So I hope you learned a lot during this video. You find something new information. If you find this video enjoyable and easy to learn, then don't forget to buy the book Case-Based Medical Microbiology. It is available as ebook on Amazon as well as uh, Google Play Store, as well as our own website, that is ql.co.in. As uh, and paperback you can always buy from Amazon as well as Flipkart. So share this video among your friends, and do subscribe to the channel so whenever I post a new video, you get immediate notification. Thanks. Bye bye. Happy learning.